Good afternoon. I'm Dr. Anthony Levinson from McMaster University, and we're really pleased today to bring to you our 11th live event. The topic is palliative care and end-of-life care, and we're fantastically lucky today to have a special guest, Dr. Giulia-Anna Perri, who's a palliative care and long-term care physician, consultant, and medical director here at Baycrest Health Sciences. And we're really fortunate to be doing this on the road here at Baycrest, which is home to CABI, Center for Aging and Brain Health Innovation. So Dr. Perri has a focused practice on geriatric palliative care and has a real passion for caring for the elderly and for end-of-life care. She's a clinician educator and is also an assistant professor in the Division of Palliative Care within the Department of Family Medicine and Community Medicine at the University of Toronto. So welcome, Dr. Perri. It's great to have you here today. And this is a really hot topic, a sensitive topic, an incredibly important topic that many people are reluctant to talk about, and maybe many people don't understand what is palliative care, what is end-of-life care. So I'm wondering if we can start maybe with just some basic definitions and talk a bit about palliative care.
Okay, absolutely. And thanks for coming to Baycrest. Thrilled to be here. So you're right, there's a lot of misconceptions about what palliative care is, who gets palliative care, when does it start, what the difference is between palliative care and end-of-life care. And my approach to the people I care for, their caregivers and family members, is to explain that palliative care is really a philosophy of care and an approach to care that prioritizes comfort and symptom control. And it really starts at the beginning of when an incurable illness is diagnosed, and it follows the patient or the individual with dementia over time towards end-of-life care, which we'll define in a second.
So maybe we can just sort of walk through this
Absolutely.
diagram. Yeah.
And I really like this visual because it really highlights how things change over time, and change is normal. As somebody with an incurable illness like dementia progresses over time, we see continual changes. But it does highlight at the beginning that at the time of incurable illness diagnosis, we start with palliative care, believe it or not. And it may be a little bit of palliative care. And what I mean by that is all that needs to be done is go through advanced care planning or goals of care. Do you know who your substitute decision maker is? And then life goes on. There aren't really any symptoms, there aren't really any crises. But over time, eventually palliative care becomes the main focus of care, and it's 100% comfort care. The way that I would define end of life, there's no real universal definition of what end of life means. Some clinicians tend to define end of life as the last year of life. Other clinicians and family health teams will define end-of-life care as the last few months of life, or maybe the last couple of hours or days. So it's really important if you're a caregiver or a family member to ask the healthcare team, well, what do you mean by that? The way that I define end-of-life care is really when someone's approaching that last year of life, and then when an individual is more in the last hours or days or short weeks, I use the language of actively dying and close to death. So it wouldn't be uncommon to hear a clinician use ranges of time just because there's no real universal definition of what end of life means.
And I would say, in my experience as well, absolutely there's a misunderstanding about when palliative care might start. I think for most people, if they've even heard the term, they think of that as, well, somebody is going to die imminently. But it sounds like the better approach is to think of it as a philosophy and to be proactive about palliative care as an opportunity to think about how to have a good death.
Absolutely. Yeah. So historically, when you would hear the word palliative care, a lot of patients or individuals living with dementia, their caregivers will say, well, that's it. There's no treatment left. There's nothing else to do. it's not active care, and the end must be near, so the last hours or days. And that's really far from what palliative care sees itself, because it does start earlier on in someone's trajectory over time. People can be receiving palliative care and still working and still living. It's very active care, and it's just the focus over time becomes more towards comfort as opposed to trying to reverse the disease itself or trying to reverse problems that come up along the way.
So although we've talked previously that dementia is an umbrella term and there's a wide range of different types of dementia and different people will have their own trajectory. It's also, we'll be doing some generalization now, but I think it might be helpful to talk a bit about some of the differences between how people, I guess, progress towards dying in dementia compared to some of the other conditions. And maybe we can just speak a little bit about that.
Yeah, and I really like this visual as well because it has the 4 main types of how we die. And the first one being a sudden death. This happens and there's really no trajectory other than somebody suddenly dies and there's no anticipation. Most people will die slower with or from one of their chronic illnesses. When we think historically about palliative care, we often think of individuals with cancer. And so the first trajectory shows the cancer trajectory, and you'll see the graph just steadily decline sharply with no plateauing. And when an individual has cancer and it's metastasized, and what we start seeing is, while our loved one is no longer walking and they're becoming more bedbound, we have some confidence as the clinical team to say, well, prognosis, we're looking at months as opposed to years. And that's been very well studied. Things are different when you're looking at non-cancer diagnoses. So individuals with end-stage or advanced heart disease or kidney disease or lung disease, their trajectory is more of the dark blue second one, where they do have a slow decline, but there's points in their life where either their disease gets worse suddenly and you'll see a sharp decline, usually a trip to the hospital. And then with all the interventions, as long as it's within the goals of care of that person, they can come up to kind of where they were in their health, and life goes on until the next exacerbation of their disease or another problem arises like infection. So there's these really sharp declines. Nobody can tell you when those sharp declines turns into, well, death is quite clear. But usually the last year of life, we're seeing these sharp declines. And then with advanced dementia, sometimes you'll hear the clinical team say a very slow dwindling course. So there's a very slow decline with little ups and downs along the way, but there's a steady decline again with no real plateauing. And even though your loved one or the person you're caring for looks okay on a day-to-day basis, they're actually declining from a progressive disease.
How do you normally explain advanced dementia to families and caregivers? We've talked a little bit about the stages of dementia, but I think more and more now people are using that term advanced dementia.
Yeah.
Maybe say a little bit about that,
Sure.
because I think that's an important definition for people.
And it's also important because when it comes to the advanced stages of dementia, a phrase that I like to use is to compare advanced dementia to stage 4 or metastatic lung cancer. So when you hit the advanced phases of dementia, which I'll describe, like what you actually see, your prognosis is similar to someone with metastatic lung cancer. So the clinical indicators of advanced dementia, there's a few of them. The first one being very significant memory impairment. What does that mean? So the person with dementia doesn't recognize their spouse or family member when they normally would. Another indicator of the advanced stage of dementia is severe impairments in what they're able to vocalize. So the words that they can articulate, and it usually comes down to just a couple of words. if not much. So it's a lot of gibberish or things that you can't make sense of. Another marker is that they lose the ability to ambulate. So individuals with advanced dementia can no longer ambulate without assistance. And then you see this gradual decline from being able to walk, requiring assistance to walk, being mostly in a wheelchair, needing help to get in and out of the wheelchair, and then becoming bedbound. So when it starts and they lose the ability to ambulate independently, you know they're in the advanced stages, as well as they're completely dependent on their activities of daily living. So things like being able to provide self-care, dressing, toileting, eating. They're requiring more support and needing that assistance. And then finally, you know, the advanced stages of dementia are there when somebody becomes incontinent of bowel and bladder. So taken as a whole, those are kind of the indicators that we look for from a clinical perspective, and that supports that an individual has progressed to the advanced stages.
I guess one of the things that we've talked about before, but when that individual is in the advanced stages, particularly because of the communication challenges, they're really no longer able to express their wishes around how they would like to die or whether they would or wouldn't like some kind of intervention, which I think raises what we've talked about before, just the importance of advanced planning and trying to understand the person's, you know, wishes and preferences and values.
Yeah, it's so critical, and it's so important to have those conversations either at the time of diagnosis, not on the day of diagnosis, of course, because it's devastating, but when the person with dementia is capable of having conversations about themselves and what they value, what they're hoping for, and what they wish for at the end of life, even though end of life may be, you know, over a year away or years away. Because although we always talk to individuals with dementia, even in the advanced stages, we communicate with them, we honor their dignity and respect, they won't be able to, like you said, express their wishes. And so advanced care planning, and I know you had a session on that, but just to highlight, advanced care planning, there's two steps. And the first is, does the person with dementia agree with who their substitute decision maker is? You don't need a power of attorney. It's always good to have that piece of paper if that individual doesn't like the hierarchy in Ontario, for example. But then it's talking about their preferences, and you'll never know unless you have the conversation of some people feel very strongly for or against certain types of treatments, and it's good to capture those in advance before changes happen.
Some of the questions we've had before, but I think are really around the last days or week or something like that. Maybe can you speak a little bit more about the when end of life is approaching, and you know what people with dementia might experience in the last 24 hours of their life?
Sure. So usually there's some forewarning. So most people in their last hours or days are either sleeping more or totally unconscious. And because of that, it seems obvious, but it's always painful when the person you're caring for is not communicating. So they're not using any words or the typical vocalizations that they use when you walk in the room. There may not be any body movement or gestures like how they used to have. So that's always difficult to see. Of course, when somebody's sleeping more or they're sleeping totally, they're not eating or drinking anything, which is natural, and it's nothing going wrong. It's everything going the way it's intended to go with this disease. But other common things that sometimes caregivers are not prepared for are you'll see changes in breathing, and you'll hear congestion for some people. And what I mean by that is you'll walk into the room and you'll see the person you're caring for and you'll hear a noise.
Okay.
But they're not in any distress, and you hear a gurgling sound. And that's normal, and all that is because they're alive and they're making saliva, their own saliva is pooling, And because they're so weak, the body needs a bit of time to either swallow it or cough to clear it. And so we monitor what we call secretions at the end of life, which is common. For some people, they may have pain from being mostly in bed and not being able to turn or adjust themselves in bed like they used to. So we may see some non-verbal signs of pain, and we have to address that. And there can be other symptoms where even though somebody's looks like they're sleeping all day long, but they're restless. So their eyes are closed and they're not eating or drinking anything. They kind of look peaceful, but then all of a sudden they're starting to move in bed or they appear restless. So that's quite common at the end of life as well.
If you had to say, what are some of the things that families have said to you afterwards are, I guess, the most surprising or upsetting signs and symptoms or things in their loved ones' dying days that they just were not anticipating, or some of those things that are, come up all the time, or challenging decisions, or what are some of what's the sort of the list that comes up most frequently with families?
That's a good question. So in my practice, because I do mostly end of life care, and I meet a lot of families and their caregivers, a lot of people hope for a peaceful death or a good death, and everybody defines that a bit differently. And a lot of individuals will tell me that they just hope their loved one goes to sleep and dies in their sleep peacefully. And oftentimes it doesn't look that way because of all the complications that we just talked about. But I would say, from my experience, when an individual with dementia stops eating and drinking, even though the caregiver knows this is going to happen, even though they have support groups or they know it's coming down the line, when it actually happens, it's actually quite painful for caregivers. And then when someone with dementia is close to death or in their last hours or days, and they look uncomfortable. So those nonverbal cues again of either they're grimacing or they're starting to moan or a tear rolls down their face. And there's this fluctuation but they were, they looked peaceful just a couple of hours ago and now what's going on? And the same thing with restlessness. I find that for caregivers, that's actually very difficult to witness and to know how to manage.
They feel their loved one is uncomfortable and suffering.
Yeah.
We've got so many other topics, and we'll probably come back to circle back to them. But it's really good to try and answer some specific questions that come in, and we've already got a few. There's a question from Hamilton about end of life care, and you mentioned that it was defined as more or less the last year of life. Because of the unpredictability within dementia and the different course, what's the best way to know that you might be approaching the last year? Are there sort of other telltale signs where you have a sense that, this is this is probably the last year?
My advice would be you're taking care of a person you care for a lot, and so palliative care really shouldn't be contingent on prognosis. Because prognosis is not an accurate science and you don't really know exactly, when's the day they're entering their last year of life.
365 years.
Exactly. The goal of care is to get impeccable care and comfort. And that can happen at any time, whether they're in their last hours or days or years living with advanced dementia. That should always be top on the list, and as caregivers, what we're asking for. So regardless of the prognosis or length of survival, you can demand for good palliative care. And unfortunately, our latest statistics tell us that only 30% of Canadians with advanced dementia can access palliative care. And it depends on geography and where you live and what resources are there. But palliative care can happen at any time and at any location of care. So oftentimes I get asked, how do we provide palliative care at home? And it depends on, what are you defining as palliative care? Because it is an approach to care. So some people do need pain and symptom control. Other folks need more discussions about goals of care and what to do when complications arise.
So we've got a few other very specific questions. Do you recommend turning, repositioning, and mouth care up until death?
Yeah, excellent question. So the short answer is absolutely. That human touch is so important at the very end of life, and for the caregiver and for the person with advanced dementia, skin integrity always becomes an issue at the end of life for a lot of individuals, not just with advanced dementia, just because they can't shift their own weight on their own. So unless shifting weight or turning is completely unbearable, we do recommend shifting positions every couple of hours. And it doesn't mean, as a caregiver, you have to turn your loved one completely on their side. You know, sometimes we just take pillows and shift the center of gravity and shift their weight so that, the point of gravity is just different. And that will help with skin integrity. But I do tell caregivers in advance that skin may break down, and it's inevitable. And what we want to do is keep any wounds that do develop clean and make sure that they don't get infected.
Sometimes in hospital settings, people will use air mattresses or different. Is that something that maybe if people have less mobility and they are at home, if they could have a softer mattress, that might make a difference?
And the evidence around air mattresses is really when we actually start to see skin breakdown. So there actually is an opening in the skin, and that's where you can ask for, or the clinical team may recommend, an air mattress moving forward.
Okay. Another question that came in, why have we discontinued the use of scopolamine at end of life? And just scopolamine is an older medicine that was sometimes used to dry mouth secretions when you talked about some of the gargling and that. And it said the new replacement drug is not as effective, if at all. Sorry, can't think of the name. Scopolamine, in my opinion, was great at reducing or minimizing the secretions.
Yeah. So there are options that are equally as effective. And in my practice, I actually rarely use scopolamine. So in long-term care, we usually use something called atropine. So it's the Atropine Eye Drops, but we actually use it in the mouth to dry secretions out, where you can use a few drops every couple of hours to dry secretions out. That was actually discontinued and then reintroduced because there was a huge uproar.
That's an oldie but a goodie. Like that's also as old as scopolamine. Like it's an older medicine.
So atropine in the hospital setting, when clinicians think of atropine, we think of like strong medication. But when given by mouth, it's actually quite effective. And sometimes with secretions, we have to use it regularly. So we don't wait for the secretions to build. We start giving it every 2 to 4 hours on a schedule because we know the secretions can be a problem. And then there's gentler medications as well called Glycopyrolate, which is probably
what this person might be asking about.
And that has less side effects, not as effective as atropine. But what I wanted to emphasize is sometimes the noise bothers us more than it's bothering the person.
I was going to ask you philosophically.
Dying.
I would have said I often felt that the drying up of the secretions was more for the family than the patient sometimes. The patients aren't necessarily suffering from it.
And sometimes what I do as a strategy, because generally caregivers are very caring and they care to make sure that there's no undue suffering, is we'll go to the bedside and we'll watch the person who's actually dying. And as long as you're seeing that they're breathing comfortably and regularly and in no distress and their face is relaxed and they're not tense, but you hear this horrendous noise, you have to make a judgment of, is this noise bothering us more than it is bothering the individual?
And you mentioned before, there was a question that came in or a comment about this is a person who's saying about nutrition and worries about their loved one not eating enough and feeling like they're starving. What are some of the ways in which you would talk with families about end of life and nutrition? I feel like this is an area where sometimes families may feel so strongly about it that you get into conversations around feeding tubes or more invasive approaches to getting people nutrition, and it may not have been something that was ever talked about with the person before they were not capable of having the conversation.
Yeah, so that's a big topic about feeding at the end of life, and my short approach, because I don't mean to gloss over it. I can spend days talking to family members because the first step is to anticipate that at some point the person you're caring for naturally will stop eating and drinking in totality. It usually doesn't happen overnight, but there are signs that they're taking less food, they're having trouble swallowing, you may hear secretions, they have some coughing after they eat or drink, and some individuals will actually refuse food and drink and get agitated with it. So we always try our best, as painful as it is, to start to forewarn caregivers that this day is coming. It will stop in totality, and when it does happen, it's very hurtful as a caregiver because we're so used to giving food equating with love and nurturing. So we start talking about alternatives. So my quick approach would be at the end of life or even earlier on, because some individuals have issues with swallowing well before their last hours or days are truly end of life. My approach would be to talk about risks and benefits and alternatives, because as a caregiver or a substitute decision maker, you need to be really well informed of what are the options here. So going into some kind of specifics, what we know from a medical perspective is that there are no medical benefits to feeding tubes for individuals with advanced dementia, which we defined a bit earlier on. So some caregivers, in a very caring way, will hope for comfort or hope a feeding tube will end suffering, maybe prevent aspirations, maybe stop ulcers from forming. So these are their goals. But what we know through evidence and kind of experience over time is that feeding tubes don't answer any of those goals from a pure medical perspective. There are a number of risks associated with feeding tubes for individuals with advanced dementia, not just with the procedure itself, but moving forward after the procedures. There's always issues with feeding tubes being blocked, leaking at the site, aspirations continue, and issues with swelling as well. So it's those types of risks as well. And then oftentimes what I notice as a clinician is individuals with feeding tubes, caregivers stop approaching the mouth, and that human touch or that connection is gone. The mouth care, the careful hand feeding generally stops once a feeding tube goes in. And we also know through experience and research is individuals with advanced dementia with feeding tubes are not more physically comfortable, and for some people they may need restraints, especially
they want to pull out, but get agitated.
They feel something and want to pull it out. So
that sounds awful.
I agree.
Okay.
So there's not just both of us, but there's big societies in Canada and in the States and around the globe that really don't recommend, for medical reasons, feeding tubes at the end of life for individuals with advanced dementia.
So there's no easy answer to this question, but I guess how do you approach families where you may have family caregivers with very different opinions or values about some of these difficult choices, when there isn't like a clear guidance, say, from the person themselves, and they're in an advanced stage, and maybe some family members are, no, I want, mom or dad to have a tube, and somebody else is like, no, we need to adopt a palliative approach. And irrespective of who might be legally named in a power of attorney document, are there approaches that you take in terms of conversations about that help people to kind of look at some of those issues?
Yeah, the main approach I use is to pretend that the person with advanced dementia, the person we're talking about, was actually present and capable of having the conversation. What would they say? Would they say to the substitute decision maker, I'm in the advanced phases, all these doctors and medical people are telling me it's not indicated, I'm ready to die, I'm ready for the end of life, I've always been ready. Like you want to honor the person's philosophy and what they value. And so sometimes when we have that guiding the conversation of, I can hear what you're saying as the person's wife or daughter that you want a feeding tube, but what do you think your dad would say?
Right.
Or what do you think your spouse would say? Knowing that it's actually not going to help with survival. And it's not going to help with comfort. And there's risks associated with it that are serious and real. So that tends to kind of get us all on the same page of, we're trying to do the best thing for the person. I mean, there are people who want to live at all costs, and they'll take the risks.
And if that was their express wish, then
you have to honor it unless it's truly medically not indicated or it poses way too much risk and it's just impossible to do.
Okay.
Yeah.
So we have another question about how effective are antibiotics during the end stages of life?
Yeah. So I like talking about this topic because we talked about, well, how do we know when end of life is approaching? So there's these indicators specific to advanced dementia. The other part of prognosticating is not just knowing how much time is left, but knowing what problems are coming our way. And the big two problems in advanced dementia are 1, feeding problems, and 2, fevers and infections. So it comes up and you will be asked as a substitute decision maker or as a caregiver, you'll experience a fever or an infection, most likely. What we know is a couple of things. The first is when it comes to pneumonias, which are common at the end of life for individuals with advanced dementia, we know that antibiotics don't provide more comfort. What we know is that they can prolong survival. So if that's the goal of care, then antibiotics are indicated. But I have the conversation often in a week with just my own practice of, I don't need antibiotics and we don't need to start antibiotics to make someone more comfortable if that's the primary goal of care. The third thing we know about antibiotics is that the intravenous route, the route by mouth, they're all equivocal. So a lot of, let's say, individuals with advanced dementia who are in long-term care homes, there's sometimes a panic that they need intravenous. As long as they can safely swallow crushed medications, because swallowing becomes a big problem at the end of life, then it's as equivocal as intravenous.
So less intrusive than starting an intravenous for the sake of it. I'm going to say that in my practice too, I find that the challenge sometimes is when somebody is not quite at the advanced stage, but maybe not enjoying the quality of life, to have that conversation while they may still be able to vocalize, if you could have treatment with an antibiotic and it would completely reverse so that you'd be back at baseline, because that's a possibility in some circumstances. But I think this is a really good example of one to have the conversation in advance before the person has the fever and the infection. It's like, okay, you may be vulnerable to a skin infection or a kidney infection or a urinary tract infection, or particularly a lung infection like pneumonia, and have them think in advance and come up with a plan to treat or not to treat.
Decisions at the end of the day about antibiotics have to be made at the time. So we use the example of a pneumonia. There's other infections. Like if anyone's ever had a urine infection, it can be quite painful and can change behavior in somebody with advanced dementia. So in that circumstance, as long as they can swallow their antibiotic, it may be reasonable as a way to provide more comfort. So palliative care doesn't mean we don't do anything, we don't give anything. It's more of a thoughtful approach to care of will the antibiotic truly help with comfort, if that's the main goal of care.
And I guess that's with a palliative care sort of holistic approach, if you talk in advance and you say, there's a vulnerability to an aspiration and an infection or another type of pneumonia, and if the family and the substitute decision makers in agreement, then you can not treat with antibiotics. Correct, and adopt sort of a comfort approach. So,
absolutely, yeah.
So I have another question. When I was caring for my husband, I was feeling very overwhelmed, especially in the later stages of his Alzheimer's. Is that normal? I felt like a bad caregiver.
Yeah, I can relate to that in that, a lot of us are in the sandwich generation, and we're caring for parents with either advanced dementia, you're caring for a spouse, and, it's all encompassing. Especially when you're providing excellent care 24 hours a day, it can really be a burden in not a negative kind of way. It's just all encompassing, and it is overwhelming. And a lot of our caregivers, at least a third of them, from what we understand through our research, have symptoms of depression or have feelings of isolation. Yeah. And it's very unique, advanced dementia, very different from the other trajectories we showed the visual on, because you start to lose the person before their body actually dies. There's a terminology for that called ambiguous loss, where you're caring for your spouse, that's your husband, but it's not really your husband who's there. They're not talking to you in the same way or behaving in the same way, and it's a bit of a paradox, and it can be quite painful. What we know can help, though, is talking about it, because it is normal to feel overwhelmed, and it's really important to talk to other people who are going through a similar experience, because it normalizes it, it validates it, and it makes it real. And that support is almost sometimes the first step in healing when you're still caring for that person.
Just the importance of maintaining your own wellness.
Absolutely.
Having those supports, connecting to get respite if needed, because it is, as you say, so all-encompassing. And I think it's not uncommon for people to feel like they're not doing a good job, because the illness is quite relentless as well in terms of, the advanced stages. It's not like no matter how good a job you do as a caregiver, the person's not going to recover. So, you're trying to offer them comfort, but it can be so taxing. So agreed, I think getting supports, connecting with your physician, being mindful of your own health and wellness and mental health. Caregivers are absolutely at higher risk of mental health issues, especially caregivers of people with dementia.
And it's okay to give yourself permission to walk away. We all need to walk away sometimes for a break, and then come back and hand over the caregiving to someone else, either for a few hours, or sometimes people will actually apply for respite for a few days because they need to self-care.
I think a lot of caregivers experience feelings of guilt and have trouble handing over the reins or taking respite as well. So that sort of a double-edged sword. They need the break, but they feel guilty whether they're taking a break or not. Here's another statement that's come in. When I was caring for my parent during her last phase, I elected to hydrate her 3 times. I found that the GP thought hydration was a minimal requirement. However, the gerontologist at the long-term care home felt that hydration was an aggressive intervention. So differing views, and I guess I'm thinking that when they're talking about hydration, they're thinking maybe it was an intravenous bolus or an intravenous hydration with fluids to help. What are some of your thoughts around that?
So with hydration at the end of life, my personal framework is that it's a treatment decision. So as caregivers, you want to get, and we need to get well informed, and you want to know why it's indicated, but again, the same framework of, well, what are the risks, the benefits, and the alternatives? So without a lot of detail, my own approach is hydration usually is not indicated at the end of life because we're anticipating totally that the individual will not eat or drink. So it would be normal and it's nothing going wrong. Mm-hmm. They will die in their sleep. They will stop eating and drinking a few days before that, or sometimes weeks, and that would be normal. So we try not to panic, even though we feel panicked. It would be normal, and there's some evidence to suggest that when individuals dehydrate because they stop eating and drinking normally, that it's actually a natural anesthetic, and they're not suffering from hunger or thirst, especially in the advanced stages of dementia and other diseases as well in the advanced stages. Sometimes the hydration is indicated, especially if there's a situation where the clinical team feels that things are reversible. So for an example, if the individual was eating and drinking and had good quality of life, but they stopped suddenly because of an infection.
And they have a bout of like diarrhea and
correct.
Require hydration.
And you're anticipating as the team, well, they're gonna get back to where they were. There's that possibility. So you make an informed decision of, yep, that's the goal of care, is to try to get back to where this person was. Other people feel very strongly of when death comes my way, let me go naturally and don't do anything to prolong my suffering even 1 second.
It's really I think it's a big conceptual shift that is very hard when we spend a lot of time as humans avoiding death and talking about death. And in healthcare, we're just as guilty. We're focused on interventions. I think it's a very different mindset to really focus on comfort and to start questioning food, drink, hydration, antibiotics, and acknowledge that we all have to die of something. What is our quality of life? Does this make sense? So I don't think it's unusual, this person's experience around making decisions around hydration, and that there might be different decisions or philosophies from the healthcare team or family members. And as you say, it's important to try and understand the context, whether or not there's something reversible and what the goals are and the wishes of the person. So, good question. Here's a question about where should we provide or get palliative care? Do you access it at home, in the hospital, in long-term care?
Yeah.
Where do I sign up for palliative care? And we have a shortage.
Yeah. So if you really believe palliative care is an approach to care, which it is, where it prioritizes comfort and quality of life, then you'll, from a philosophical perspective, you'll appreciate that anyone has access to palliative care. And as clinicians, we all have the basic competencies to deliver good palliative care in a general kind of way. So palliative care doesn't have boundaries of you only get it in a palliative care unit or a hospice or in a hospital. Palliative care is delivered very successfully in someone's home or in the long-term care home environment. So that's surprising to a lot of people. You don't need a palliative care specialist. Sometimes you do, if things are a bit complicated and depending on the situation the person with dementia is in. Sometimes a consultant or a specialist in palliative care will come in, give their opinions or recommendations, and then step away, and the regular care team continues. And sometimes with palliative care teams, they take over care because things are really complicated and they're needing a different type of support. But to answer the question, really, it's everybody's business, and everybody should be able to provide palliative care, going from the physicians to the caregivers. Like, we all want to be able to talk the same language and provide the same goal.
And I think the question is coming out of the fact, though, that not everybody is able to
Yeah.
access clinical care that is maybe informed by the palliative care ethos.
Yeah.
If you're in certain, as you say, a lot of it came out of cancer care originally,
Yeah.
and I think that's when more specialized people. But now I think there's an appreciation that there is a shortage of sort of specialty trained experts in palliative care,
Yeah.
and that all physicians and care teams and nurses need to
Yeah.
adopt some of these competencies and
Yeah, and
skills.
well, I remember, just as a quick story, when I went to medical school, and even as when I did my specialty training, I mean, palliative care was really, nobody knew about it, or what is it, and what does it mean? So things have really changed. All our medical students and all nursing students and professionals have basic training on what palliative care is and what does it look like. And then there's our folks who will kind of specialize in terms of a team to provide more support and education for the clinical team. So it's evolving.
One last question before we wrap up. Can opioids be given safely at end of life?
Absolutely. So opioids, some individuals use the word narcotics.
Narcotic drugs.
If they're indicated, can be safely given at the end of life. We use opioids not just for pain, but also for problems with breathing, when the breathing muscles are just working too hard. We rarely get into trouble with opioids at the end of life, as long as an experienced clinician is prescribing them. But often, right at the bat, when I think as a clinician, opioids need to be prescribed for pain or shortness of breath, you want to dispel some myths off the bat that, well, it will hasten death or bring death closer, or the individual, even though they're close to death, will somehow become addicted, or they'll become so sedated. Like, these types of complications don't really happen at the end of life when they're truly indicated and being prescribed by a clinician for that intention.
That is all the time we have today. I want to thank Dr. Perri for joining us today for a really informative conversation and Q&A on just an absolutely crucial area in this field and more generally. I want to thank Baycrest for letting us host our event here. Obviously thanking Dr. Perri again. Funding for iGeriCare is provided from the Canadian Centre for Aging and Brain Health Innovation, or CABI, powered by Baycrest right here. Additional funding's been provided by the Gerris Centre at Hamilton Health Sciences, McMaster University, the Hamilton Health Sciences Foundation, the Alzheimer's Society Foundation of Hamilton Halton, and our Division of E-Learning. We're also really pleased that we've had donations coming in to help maintain the site. So without going to fundraiser on this, we really appreciate your donations, and it helps to continue to bring you the iGeriCare service and these live events. Our next live event will be Thursday, October 17th at 1 o'clock. I'm going to keep the topic a secret. You guys have voted and continue to vote, so please continue to fill out the survey, give us feedback on the live event, and also future topics that you would be interested in. Also want to thank our road tripping Division of E-Learning team, Jamie, Mike, Stephanie, and those working remotely. As always, teamwork makes the dream work. So thank you very much, and we'll see you next month.